To this meeting of the Adults and Health Scrutiny Board. I'd just like to say this evening before we begin that unfortunately Lindsay Stevens, the scrutiny support, is unwell at the moment, is unable to be with us, so we're in the very capable hands of Dom, but he has requested that the external guests introduce themselves at the beginning, if that's all right, so that he is aware of who's here. And can I just remind everybody that because we're being recorded, and also for the sake of at least me certainly being able to hear you, would you mind speaking into the microphones, please? And then when you stop speaking, turn them off. So I don't know if you want to start over here introducing yourself. Thank you.
Yeah, I'm on it. Thank you. Good evening, everybody. My name's William Jones. I'm Chief Operating Officer and Deputy Chief Executive of the Derbyshire Community Health Services NHS Foundation Trust.
Hi, Andy Harrison. I'm the Senior Responsible Officer at Derbyshire Healthcare for the acute mental health builds.
Hello, I'm Mick Burrows. I'm Director of Mental Health Commissioning for Derbyshire CCG. I also have children, young people and learning disabilities and autism in my portfolio.
Hi, I'm Becky Harrington. I'm Deputy Director for Population Health Improvement at UHDB.
Hi, I'm Duncan Bedford, Executive Managing Director at Burton, predominantly, but I'm all part of UHDB, University Hospitals of Derby and Burton. Thank you.
Right, thank you very much. And Dom assures me he knows all the councillors present. So for apologies, we have Councillor Foggett. Do we have any other apologies?
Apologies for Andy Smith. Thank you, Chair.
Thank you very much. There are no late items. Does anybody have any declarations of interest? Councillor Pegg.
Yes, my mother is in receipt of home care provided by Derbyshire Council.
Thank you, Councillor Pegg. Any others? No, thank you. So do we all the councillors accept that the minutes are a true record of the last meeting? Thank you, Councillor Cooper. Thank you very much. So, very quickly then, we move to our first report this evening, which is on the Florence Nightingale Community Hospital, improving health in Derby City, and Becky Harrington is going to present that, along with Duncan Bedford. Thank you.
Thank you. Will the slides come up? Yeah.
Thank you.
Thank you very much, Chair. So we've come along today just to talk to you about improving health in Derby City, and specifically around how we collaborate at Place. Just before I go into the presentation, just to discuss a bit of our strategic intent and to probably get three key points across, really. The first point is around where the NHS is trying to get to at this moment in time, and specifically around the triple aims. So what we're trying to do is ensure better health for everyone, better care as well for everyone, and effective and efficient use of our resources. The second key point that I wanted to draw upon is when I touched on collaboration at Place, the NHS has moved away now for a while, away from a competitive environment, and is working with all of its partners, whether that be in the NHS, voluntary sector, with the local authorities, to provide a more integrated service provision. And then thirdly, I think as we go through the presentation, if we can just have a bit of a focus and a thought around, it will touch on the prevention agenda, which is where we're trying to move to. So briefly, we came together just to look at initially how we could utilise the Florence Nightingale Hospital more effectively and more efficiently. But as a group, And as we came together with our various partners, what soon became very apparent is how we could shift and move to an integrated hub. And this could be much more powerful than just health. So our partners from the local council came along and joined us, and as I said, the focus shifted to that of health prevention, preventing crisis, and specific diagnosis and treatment that could be achieved through the Florence Nightingale Hospital. But I'll hand over to Becky, who's done a lot of the heavy lifting around this work, and she'll take you through the main part of the presentation.
Thanks, Duncan. So, yeah, as you can see up there, the membership of our group that basically plans and develops a vision for Florence Nightingale is representative of the place now, Derby City Place, and our focus is on improving population health and addressing health inequalities for the whole of Derby City, covering the populations in the 5 city PCNs, rather than just looking at how we can use Florence Nightingale to as an overspill and a pressure release valve for acute services. Could you move on to the next slide, please? So I just want to sort of point out, and I'm sure you're all familiar with the geography, but if we look at the location of Florence Nightingale in relation to the various different wards in the city, we can see on this that Florence Nightingale is right sort of in the middle of a number of relatively deprived areas. So the colours on the map, I'm sure you're familiar with this map, but it shows indices of multiple deprivation, with the red being areas of greatest deprivation and green being areas of least deprivation. So Florence Nightingale is really well located to work with and address the needs of a number of these populations. Could you move on to the next slide, please? So the following few slides just set that out and show you a few maps that give you an idea of mortality rates, disease rates, and indicators of disease rates against that sort of map of deprivation. So the first one shows you mortality rates due to coronary heart disease and stroke, and you can see it's not exact with these, but you can see correlation between higher rates of mortality in those areas where deprivation is at its greatest. If you could move to the next slide, please. Thank you. Similarly with emergency hospital admissions, again due to COPD here and to stroke, correlation again with a lot of the focus being around that very central part of the city, which again is very close to the location of Florence Nightingale. And the next slide, please. Okay, if we move on to correlation between disease and lifestyle habits, again, these are just examples, but again, you can see those central parts of the city where there's greater levels of obesity correlating with greater levels of diabetes prevalence. And the next slide, thank you, shows the same for smoking prevalence and hypertension. So we're very lucky in many ways to have Florence Nightingale Community Hospital located where it is. We're in a really good position to use that facility as a community asset to address some of these population health needs. If you could move on to the next slide, please. So, as I'm sure you're aware, Joined Up Care Derbyshire has identified the following population health priorities as ways to improve health outcomes across the city and across Derbyshire. And they're all the things that you would expect. So looking to focus on reducing the prevalence of smoking to below the national average, reducing obesity, increasing levels of physical activity, reducing levels of harmful alcohol consumption, and reducing the number of children living in poverty. So we want to use, as a multi-agency group, we want to see how we can make best use of Florence Nightingale site to ensure that we're contributing to these prevention approaches to healthcare. If you could move to the next slide, please. So this slide just gives you an overall picture of the vision that we've developed through that group. And I'll take each bit, each part in turn, but this gives the overall picture. And as you can see at the top, we're looking for an integrated city centre hub that will be focused on improving health, reducing health inequality, preventing crisis with people ending up in ED and adult social care, and providing easier access to diagnosis and treatment. So if I could move on to the next slide, I'll just take each of those blobs in turn. So there are already a number of long-term conditions clinics that run out of Florence Nightingale, and they'll continue. We're looking to move more long-term conditions clinics onto that site. And we want to pair those up with Live Well services. So Live Well have now moved on to site, and they've started working with our long-term conditions clinics and the consultants and other clinicians who run them to make the prevention pathway part of the treatment. So having seen a patient in a clinic, we're looking to have a direct referral set up to Live Well and ensure that prevention and coach support to stop smoking, to reduce weight and to increase physical activity, ensure that is seen as part of the treatment pathway. So that's a big part of the vision, and we've started putting that vision into reality. We're also linking in, using those long-term condition clinics to link in with primary care. So we're looking at the potential for moving some of the PCN additional roles into those clinics. And linked to that, on the bottom right-hand side, are some of the other suggestions and ideas that we have for expanding the use of the site and ensuring it's used as a community asset. So we're looking to bring voluntary sector onto site, some community programmes, and use the whole of that site and the facilities within it, which are really fantastic, such as kitchens where we or voluntary sector can provide healthy food preparation and cooking, the option for bringing a fruit and veg stall on site, running gardening clubs and various other activities that would help support people over a number of different, with a number of different challenges, whether they're physical health related or mental health related. If you could move on to the next slide, please. So that provides the sort of overall generic approach that we'd like to take to ensuring that we bring prevention into our treatment pathways. In addition, we're looking to bring in Team Up onto site and combining Team Up with the local area coordination, some of the local area coordination services to help prevent people reaching crisis point, ending up in ED or adult social care. And again, having all of those services co-located on the one site, there will be much better integration between Team Up and health improvement services and voluntary sector. If you could move on to the next slide, please. Okay, in addition to that, we're developing We already have diagnostics services on Florence Nightingale site. We're looking to expand those. There's been investment in community diagnostics hubs nationally, and Florence Nightingale has been recipient of some of that investment. So there will be an increased provision of community diagnostics from the site. And again, we're linking that into our long-term conditions clinics. So ensuring that we provide diagnostics there, which enables us to bring more of our long-term conditions clinics onto site. Also, there are plans to bring a pharmacy on site, again in support of services such as rheumatology, who regularly prescribe medication, which at the minute people have to go up to the main site to get. If you could move on to the next slide, please.
Okay, do you want me to,
yeah,
sorry,
do you want to summarise?
So in summary, the vision and the fit dovetails neatly with the long-term plan, and also system working in Derbyshire through Joined Up Care Derbyshire as well. The focus, as Becky's described, is on addressing the health inequalities, which is fundamental. The focus is also on integrated working, and as Becky's described, working with existing services like Living Well, the Living Well service around smoking cessation. This being seen as part of the treatment pathway will certainly enhance the care that we deliver to our patients. Care closer to home, Florence Nightingale provides an excellent asset, a community asset, to be able to do that in a more rounded way. And finally, again, as Becky's described, hopefully if we get this right and we shift the emphasis towards prevention, it should allow us to reduce the overall activity which is coming on to the acute hospital as well. Thank you.
Right, excellent. Thanks very much. Any questions from councillors? Councillor Cooper.
Thank you, Chair. Those of my colleagues on the committee will remember that I always discuss about prevention methods. It's really important. We recently had from Chesterfield Hospitals discussing stroke treatment. And my question was, what prevention are you doing? And so it's absolutely fantastic to see that this is being considered. Going through the slides, you showed some slides about links between deprivation, health outcomes, prevalently in the city centre, moving into the suburbs, but particularly in the city centre. However, there is a few pockets that we all know about within our wards, even wards where you wouldn't expect as well. So the question I've got is there any consideration for your organisation doing outreach work within certain areas? Because sometimes some people don't want to engage. I regularly bring up about smoking. I stopped smoking recently, thankfully, especially for my bank balance. But I wouldn't necessarily want to engage with NHS because I dealt with it myself when I was ready. However, some people may want that but not want to come to the hospital. So outreach work-wise, could you just give us a talk through what you think you can achieve and what's realistic? Thank you.
Yeah, sure, absolutely. So there are already Live Well who provide those stop smoking services, and they provide up to 12 months of coach support to stop smoking. They operate out of a lot of venues across the city already. To date, they haven't operated out of Florence Nightingale. So they engage in a lot of primary prevention, which is stopping smoking for the general population. What we're looking to introduce here is secondary prevention, i.e. people with already diagnosed disease being able to access those services and being referred to them, so it's part of their treatment pathway, rather than it just being here's a phone number, ring this. So to make it more, much more a sort of prescribed part of their treatment, rather than, so they already operate in lots of different city locations, and what we don't want to do by having Live Well on site is to stop any of that activity going. This is additional to what they already do. The other thing just to mention in relation to that is is the Cavel Centre development at Symphony, which obviously there's many similarities in what's being planned for that site and what's being planned for Florence Nightingale and what's already been put in place at Florence Nightingale. So we need to make sure that we don't duplicate or overlap or leave gaps between those. So we're making sure that we plan the development of both of those sites, together within Derby City Place rather than separately.
Just to pick up, I think, in terms of just very quickly, a broader aspect of your point is, I think, it is noted in terms of...
Could you speak into the mic, please?
Sure.
Thank you, because I can't hear you. Thanks.
In terms of, we're on a journey and we're collecting and we're trying to get better information or be better informed by the data which we provide. And so we are conscious of, whilst Becky's talked about the inner city, there are other areas, and I deal with some of the Staffordshire areas as well, whereby we do need to focus and make sure that, it's equitable across the patch. But we'll take that point back. Yeah.
Thank you very much. Councillor Lonsdale.
Hello. I think it's a good plan, good idea to do this. What I was wondering about was if Florence Nightingale is currently the pressure release for the NHS in Derby, and we're going to be replacing that, where is that facility going to go? Where are we going to say, right, where is the pressure release going to go?
Yeah, I think there's still plenty of opportunity and capacity, I would say, at the Florence Nightingale Hospital for us to be able to balance, and that's part of my role at the moment, for us to be able to balance the agenda which we've just described, but also to get it right in terms of meeting care closer to home, but also addressing some of the pressures that we also have on the acute side. So we have moved some outpatient departments down there already to allow us to expand our emergency department. But there is capacity, I think, if we can get it right and design it right, to be able to balance both agendas.
Thanks. Yeah, just before I bring in Councillor Hussain, just to quick, because it's the same point really, I would add to that obviously at its last meeting this committee recommended that you do not permanently close all the rehabilitation beds at what was called London Road and now seems to be called Florence Nightingale. Has it officially been moved to Florence Nightingale now?
It has, yes.
Thank you. So Florence Nightingale. So we will stick to that point, please. But that doesn't take away from all the good work that this initiative promises and actually builds a lot on what Live Well have been doing for some time. But I'll bring in Councillor Hussain. Thank you.
Thank you, Chair. It's difficult to criticise what you're trying to do, and I think it needs to be welcomed because it would be a step in the right direction if you were able to take it eventually in a proper manner. The reason I'm saying this is, I'm sorry if somebody's heard me before on this. I got elected to the council 30 years ago, and in my first year on the council, we had a presentation from a Dr. Whitehead, who was a public physician based at the DRI at the time. And he was the first person from a medical background who was working with the communities, and he brought a report which left all the councillors present at the presentation speechless. He identified 30 years ago that the life expectancy between the richest wards in the city and the poorest wards was around 11 to 12%. And Elstree being the richest ward at the time, and Arboretum and Normanton being the poorest. That gap is still there, and it may have grown slightly. Some of the initiatives that you are trying to get off the ground with your new philosophy have actually been tried, but for some reason, nothing seems to have worked. For example, smoking cessation programs was quite extensive about 12, 13 years ago, before the Tories got in the Westminster. We had dedicated smoking cessation officers in the city. And those jobs were eliminated or dismantled, and they're no longer there. We also had a team of workers, in view of what I've said, who were additional to what was available in other parts of the city, but because our Tory friends cannot see any additional inputs going into the areas which are most deprived, because they want to equalize everything regardless. And they've done a number of things which have kind of pushed them in that direction. Even with the sport that we have with the not community care workers, but the title is something else, but I can't remember what the title is now. But initially, we had more dedicated support going into wards which were most deprived, but the Tories said, no, that's discrimination against people who are relatively well off. So therefore, we need to be spending equal amount of time, regardless of whether it's, they've not said it, but the implication of what they've done has been exactly that. I'm sorry, it's been a bit long-winded. The question I want to ask is, could you give me some reassurance that the steps that you are trying to take will actually make some difference? And when can we expect some results coming up the surface? And when can we notice the difference? When will you reverse the trends which are already there? And what can we expect in 3 years' time, 5 years' time?
Yeah, I mean, I appreciate a degree of scepticism is there in terms of this has been done before. I think if I just allow Becky just to talk about what she's done already, linking into with some of the clinicians and linking the Living Well services, I think he's already starting to have, however little one wants to describe it, an impact. Do you want to just describe some of the work that you've done? And
yeah, sure. So I think I take your point. There were initiatives to stop people smoking a number of years ago that were primary care based, and those initiatives continue. And if you look at national data, I'm really sorry, I'm not familiar with local data, but certainly national data, we've seen significant drops in smoking rates as a result of those programs. What we haven't done up to now in the health service generally is focus those prevention services to people who have diagnosed disease. So we don't, within our hospital walls, where arguably we're seeing the most ill people in our communities, up to now we haven't encouraged them or referred them into prevention programs. And actually, there's a lot of suggestion that if we do that, you're catching people when they are acutely aware of their ill health, and perhaps are more likely to take action to address some of the behaviours and lifestyle habits that they have. So by supporting them and referring them in this way, and making it part of the treatment pathway, we would hope that we would have a greater impact. As to your point about, when will you see the results? You should, if 100 people stop smoking tomorrow, then those people will, for the rest of the year, use hospital and health services less. So you should begin to see impacts immediately. What you won't see, probably, are those impacts appearing in population health figures and health inequalities data, because that takes longer for those effects to be seen on a population wide basis. So I hope that answers your question.
Okay, thank you. So if there are no further questions, I'd like to thank you very much for the report. I think we do really welcome the initiative. I mean, we recognise that it's building on many things that have happened before, not least the council's very successful Live Well service, and we know that funding for that has been in doubt recently. I understand they've got some more funding, so obviously we recognise that for you to have any sense of success, funding is important. I think Councillor Hussain's point is a very valid one, that we would like to see health inequalities reduced in Derby. So I suppose, would it be fair to consider that you might come back to this committee in a year's time and report, who I may not be the chair then, we don't know, but maybe that could be noted, Dom, that you could come back in a year and try and advise us on how it's all going. Yeah.
Yeah, happy to do that.
Delighted to, yeah.
Yeah, thank you very much. Thank you.
Thank you.
Okay, so our next report, we're just waiting for Kirsty McMillan to come in. Kirsty is the Director of Integration and Direct Adult Services Adults in the Council, and she's going to talk to us about home care services and the home care market in Derby. So here she is. Hello, good evening, Kirsty, and welcome, and thank you for coming. Yes, we seem to have it up on our on the screen. I think Dom, I don't know where, has Dom just gone to look for you? I think he may have gone out to look for you, Kirsty. I said you were... Oh, he's coming back in now, we're okay. So who should be able to, thank you, Councillor Cooper. So we've got yourself and Dom back in the room now. So we're ready, when you want to start, Kirsty.
Okay,
it's all yours. Thank you.
I'm just going to load up my computer. While that's doing that, I'll introduce myself then. So I'm Kirsty McMillan, Director of Integration at Derby City Council, and I've got a colleague with me who I'll let him introduce himself, if that's okay.
Good evening. My name's Kevin Day. I'm the acting lead commissioner.
Sorry to interrupt, but could you turn the mic on and also speak into the mic, please? Because unless we don't speak into the mic, we can't hear you, or I can't. Thank you.
Sorry, is that okay? Good evening. My name's Kevin Day. I'm the acting lead commissioner for communities in adult social care.
Kevin's first time in the chamber as well, so I probably should have prepped him about the mic. So yeah, I think the panel wanted just a general overview about the home care market. So shall I just talk through this? I know we've got 10 minutes and then some time for questions. Can you move it forward?
If I may interrupt, Kirsty, if you don't mind, before you begin, just on behalf of the committee, I know I have read the presentation and I know full well, as I'm sure all the councillors do, that one of the problems we have in recruiting is because the profession is held in low esteem and people do not feel acknowledged for the work you do. And on behalf of the committee and the council, really, before you begin and we talk about the problems with the home care market, I'd like to just say that we do recognise, acknowledge and value the work of carers, and we know it's a really difficult job. We know it's underpaid, and we know that it doesn't get the recognition it deserves, and we do thank all the carers, the people working in care, for the work they do. Thank you.
Okay, thanks very much. So yeah, I've just done a quick summary really, and like you said, you've already read the presentation, so I won't go through this bullet point by bullet point, but what you can see on the screen are just some of our sort of statistics around home care, and I can answer any questions about some of the specifics if you need me to, but that's to kind of give you the scale, and obviously this is just for Derby City. For Derbyshire, it would be treble that. So, you know, the scale gets bigger with the geography of Derbyshire. So, Dom, do you want to just move this one on? Thank you. How we operate in Derby is we have a number of providers who form what we call our framework. And we've recently, Kevin very helpfully retendered sort of contracts that we have, and you can see that we split them geographically. So on the right-hand side is just the name of the organisations that we work with. But the reason that there's a deliberate reason for splitting them this way is so that they can have kind of, I wouldn't say an economy of scale, but they need to be able to recruit enough staff to manage the work. So, you know, what we can't have is just one or two organisations, because that puts too much risk into one or two players. But you can see that some of them operate in more than one area of the city. But these aren't the only providers that we work with. Ideally, we would give all of the home care work that we need to these providers, but actually even these providers are struggling at the moment to accept all of the care packages that we need, and so we have to use providers that are still operating in Derby, but they're not necessarily ones that have made it onto our tender. And that's just the scenario that we're in at the moment in terms of the fact that, you know, the severe pressures in the capacity. So Dom, if you can move on to the next slide. I mean, a lot of this has actually been in the press very, very recently, and providers in Derby are no different really to others in the sense that there is severe pressure on recruiting and retaining care staff. This has absolutely accelerated since the COVID restrictions were eased at the end of the summer, or the middle of the summer, I suppose, without a doubt. I mean, in Derby, we never used to have a waiting list for care, but in the past 3 months, it's just sort of shot up. And what providers are telling us, and Kevin speaks to providers most days, is that they are losing staff to other sectors. So as society reopened, as the economy reopened, people who had sought work have gone back to other professions really, or other industries that appear to be more attractive to them. So it's not necessarily that they're being paid more, because a lot of them are going to areas of the economy that are equivalent, I suppose, in terms of the way that the salaries are structured. But actually, you know, it's difficult work being a carer. You know, you have to have a lot of training, and we are finding that the more experienced staff are actually just leaving. You know, they've kind of given their all. The pandemic obviously was a really big effort, but actually we're just not able to recruit back as people are leaving. And so the biggest issue we're having at the moment, which colleagues from the NHS will be aware of who are in the room, we just are not able to get packages of care for people. And we are literally getting single figure numbers a day coming through to us, whereas that would have been unheard of even in sort of the spring of this year. So if you can move it on for me. I mean, there's obviously a lot going on about trying to raise the profile of social care, and there's been various reports. In fact, one was published yesterday, which was a survey done by the directors of social services, and you know what it was showing was literally hundreds of thousands of people around the country waiting for care at the moment. So, you know, there's a real groundswell about this, and it's particularly difficult as we head deeper into winter. Clearly, there's an impact not just on the NHS in terms of hospital discharge, but, you know, if people are living in their own home and cannot get the care that they need, they will pitch up at NHS access points somewhere, whether it's the hospital, whether it's trying to get through to their GP. Either way, there will end up being a crisis because we are effectively not able to meet the needs that are out there at the moment. I think you were mentioning at the beginning that there are some pressures around the finances, because essentially the care market is funded by either people organising the care themselves or councils or the NHS paying for care on their behalf. And there's a lot of factors that contribute how much we're able to pay. And actually, generally, it is a minimum wage sector. You know, most staff are not earning much more, although they might get some additional benefits in their terms and conditions. And the impact globally, I suppose, certainly for Derby, people are leaving. So providers who are effectively private sector providers are exiting. So they're closing their businesses down. And we would expect that to accelerate, if I'm honest, over the next 12 months. And that is replicated everywhere. You know, again, Derby's not unique. And then the next slide, Dom, just got a couple more slides really about what we've been doing as a council. We're absolutely having to review every single person on the waiting list, and Kevin will know because I'm looking at it daily. You know, going back to social workers, going to families, having difficult conversations to say, you know, there's nothing coming down the track anytime soon, and really double checking whether the need is absolutely urgent. And, you know, that is a really hard task for staff to do because that's not what they necessarily came into social work to do. We work incredibly closely with the hospital, got a team in the hospital themselves, and they're also making sure that the only care that's sort of commissioned from hospital is absolutely essential. We've got people looking, the providers themselves are looking at the packages of care, and Kevin, again, if anyone wants any specifics on that, is talking to providers about, you know, ideas that they've got because they're out on the ground every day working with individuals. And we're trying to do our best to divert people elsewhere, so using things like assistive technology, making sure that the voluntary sector, any kind of peer support or informal support that can be put in place is absolutely maximised. There's some regional work going on. Like I said, this isn't unique to Derby. I'm quite involved in that, which is, again, working directly with care providers. You know, that they will have some of the solutions potentially, and it's trying to work with them to see whether, you know, they've got ideas that we can facilitate as best as we can. The thing that I think is probably the worst news that's coming from a care provider's perspective in terms of what they're telling us is the fact that the mandatory COVID vaccinations being extended to all care staff. And we already know that the take-up in home care is much, much lower than care homes, you know, significantly lower. And actually, this is just going to really bring additional pressures to those providers. But, you know, we all understand why this is important and it's needed, but it is something that, come the spring, is going to absolutely cause significant pressures, I think. And then a couple of slides just to do with the quality, and this is how we try and make sure that the care providers we work with are of sufficient quality as possible. So I won't talk through this in detail, but this Care Quality Commission provide ratings around home care providers. They try and do on-site inspections at the moment. Previously they would have done, but because of the COVID restrictions, that hasn't been as possible. And what we've got on here is just a sort of visual guide to where the current providers are that we're working with. Some of their inspections are quite out of date, more than a year. So I think if the Care Quality Commission was able, it would probably be going back to try and have a look, and they look at a variety of domains when they do their visits. And what we do, if you can move on, Dom, is we make sure that our contracts have got quality standards that are clear, and we've got a team of quality monitoring officers. It's a small team, and they try and do their best, particularly during the pandemic, to support the care providers in ensuring the quality that we need is met. Every home care provider has a dedicated officer, and there's lots of contact. At times it can be daily, but I'd certainly say it's weekly at the moment. And we have reinstated our meetings where we're going out to actually meet the providers. There were obviously restrictions on that where we weren't able to do that. And that's in addition to virtual forums that we have with them, contract management meetings. And the other thing we do is look at a wide range of information that we can gather about the quality, whether that's feedback, complaints, talking to social workers, other professionals. We work with the NHS about their information. So, you know, we use a range of sources really to establish whether providers are offering good quality services. And if we have to, we will suspend provider contracts. I think what's particularly difficult at the moment is we really do need, we need a win-win scenario. So having providers who are unable to take care packages because of a suspension, it is no use to anybody at the moment. So it's quite challenging to get the balance right between working with providers who might have quality issues but not sort of pushing them out the door, because, you know, we really do need them. And then our general approach to improving quality, which is the last slide, if you can just move it on, is that we do lots of supportive work with providers where we do have quality concerns, and we do a lot of this with the Care Quality Commission as well. And Kevin is our lead commissioner for home care, so over the past 6 months or so he's been really building up the relationships with providers. This is very much a carrot rather than a stick approach, in the sense that we all want providers to succeed. It's a partnership, really, a collaboration. If we could do more visits with providers, I think that would be really, really beneficial. It can be, Kevin and I were talking about it outside, it's very challenging to sort of really get to know an organisation when you're doing it remotely. But, we are doing some more visits, but, it's been a long period where some of those relationships have had to move into a virtual space. So that's all the slides. More than happy to take any questions.
Brilliant, thank you very much. Councillor Hussain.
Thank you, Chair. I have 2 questions, actually. So if I could put my first question to you first, which is around Nightingale Hospital losing some rehabilitation beds, because we had a presentation at our last meeting, and it was argued that more people will be provided with rehabilitation type services in their own homes instead of receiving rehabilitation in hospital settings. Now, obviously, it's a good idea. Where possible, people should be rehabilitated in their own homes if that's their ultimate destination anyway. What worries me is what you've said, that you're already struggling to provide adequate services to vulnerable people who are already in their own homes. Now, this is likely to add to your existing pressures, because although health authority might pay for that staff, but you are fishing in the same pond, aren't you, for the staff? Now, if there are more people who are going to be in need of that service, and there's less and less people who are interested in that, providing that service, or, people who are working in that area of work are leaving in droves because for one reason or another, they are finding other jobs which are enough or more attractive. But I would also like to add, and I'd like to ask you another question, because back in the days when I was still a practicing home care manager, zero-hour contracts were widespread in the private sector. And it was a bugbear to many, many people who were working 1 week, they were getting 40-odd hours. The next week, they were only working 10 hours. Or another week, they were not working at all. And actually, there's nothing more off-putting than not knowing what income you're going to have next week or next month or the month after. Can you tell me if that's still happening? And secondly, home care staff, when they were traveling between service users from one to the other, in some cases they were not being paid. They were only being paid for the time that they were spending with the client. Is that still going on? And if those things are happening, then is anybody surprised that nobody wants to work in that sector?
Okay. If I just start with, I think, obviously I wasn't here for the previous item, but I think we were talking about Florence Nightingale and, yeah, okay. I mean, there's no doubt about it. At the moment, staffing, whether we're talking care or NHS staffing, is really, really challenging. So with the best will in the world, I think we all would prefer people to get all their care, rehab, post-hospital support at home. That is absolutely the direction of travel. But we simply cannot meet the demand for a number of reasons. Like I was saying, the workforce issues in home care have absolutely accelerated in the past 3-4 months. But also the demand for NHS service has also accelerated. So we've kind of got a perfect storm. So I think, you know, with the best will in the world, our intention as a health and care system is still to try and keep people at home. That is what people want. They don't really want to go anywhere other than home from hospital, and they want to stay at home if they are at home. But it is very challenging at the minute. We can't meet the demands. We can't meet the demands for people in the community or coming out of hospital. And I think that the reason that we're having to consider non-ideal sort of options for people is just really, as we head into winter, we have to have a range of options, however sort of unideal they are, because if we hold out and say we're just going to get people home, we will have people blocking the beds in hospital because we will be waiting. I mean, like I said, I think yesterday, Kevin, did we have 5 packages come available?
Yes.
And that's against a waiting list of about 80. So 5 a day, you can do the maths, it's going to be slow stream before all of those wash through. And of course, more are coming in all the time. As far as the kind of terms and conditions for staff, again, it is such a fast moving picture at the moment. I would say that the providers, and Kevin will probably have more detail than I, are offering any type of contract that anybody wants. They are so desperate to retain people that the incentives that they're offering. So some people will still want to use 0 hours contracts because, when I say people, I mean staff, because that gives them ultimate flexibility. But a lot of providers are offering permanent contracts. They're offering, it's not just travel time, they're probably providing mechanisms for people to move around, whether that's vehicles or taxis. It really is an employees market at the moment because they're so desperate for staff. They really are. Whether it will settle down and actually some of those more, I suppose, difficult terms and conditions creep back in, only time will tell. But certainly at the moment, I think employees can pretty much get their pick of the flexible working arrangements that work for them. That's certainly how we're doing it as a small provider, as the council, is that actually if we get someone who is interested in the job, then we will work with them to create a way of working, a pattern of working that's as flexible as possible. We have to be, we have no choice.
Okay, thank you. Just before I bring in Councillor Pegg, I mean, one of the range of options that this committee has told the CCG that it would like to see available is the reopening of some rehab beds at what is now the Florence Nightingale Hospital, which I understand isn't happening, but I know that isn't your area, Kirsty. So just to reiterate that it is the view of this committee that is premature and possibly and probably a mistake. But Councillor Pegg, thank you.
Thank you, Chair. I have a few questions. Firstly, the one more from my own understanding. So out of the 7 framework providers, I take it then of all the other home care providers are off framework. Are there any plans to bring more onto the framework, or what is the difference between the two?
Yeah, I'll let Kevin answer that one, but we do have an option to do that?
Yes, thank you, Kirsty. At the moment, we work with a further 20 providers who we would class as off framework. That simply means that they aren't our first port of call to place those packages, as in the table you saw earlier. However, each one of those providers does have a set of terms and conditions with ourselves, which includes the same quality measurements and payment details and so on and so forth. So it is as regulated as our framework. That does give us obviously more choice and flexibility. It does make it harder for us to manage the market, because obviously we'd have to work with 27 providers rather than 7. And also there sometimes are some issues with the sustainability of some of those smaller providers who only have a handful of packages. So they find it harder to operate, they don't have the economies of scale, etc., of our framework providers. So that's the position at the moment.
Thank you. Next question. Of the 86 home care providers, how many do the CQC rate as below good?
I haven't got that to hand, but we can probably get that to you. So the ratings, the lowest rating is inadequate. I mean, generally, before the pandemic, there was at times none that were rated inadequate, or just a handful, but that may well have changed. What we're finding, or what CQC are finding, is when they go back in now, post-pandemic, or as we're still in the pandemic, but since the visits have recommenced, they are finding areas of poor practice. Partly, I think, because of the pressure of the work, but also, I suppose, if you haven't had the same level of scrutiny, sometimes some standards can slip. So I would imagine that now the numbers are slightly more, but we're still talking a small percentage. Most are in the requires improvement or good. I think we've got very few that are outstanding, possibly 1 or 2.
And do you have a sort of time frame to work with the ones that are sort of less than good to try and bring them up to be good or higher? I know the pandemic will have a big impact. I mean, in normal times, if we can ever go back to normal times.
Certainly ones that are inadequate or requires improvement, the Care Quality Commission will want to go back and visit them more frequently. So in that intervening period, we would definitely want to see an improvement plan, want to visit them more frequently. Ones that are classed as good, they just get less attention, to be honest. So at the moment, the timescales are not as normal, but I mean, we would be working with someone, I would say, on a monthly basis if they needed to do that level of improvement.
And will that go for if a care company has been rated inadequate twice in 4 or 5 years?
Yeah, I mean, I think if they've been rating inadequate on a consistent basis, from our point of view, and this is a bit what impacts whether people can have a contract with us, you can't be rated inadequate at the point that you apply for our tender. So, things begin, then the net kind of closes in if you're rated as inadequate. We haven't talked because we haven't had enough time, but the fact that there are 86 providers in Derby cannot be sustainable. That is just too many. And actually, there's going to have to be a fundamental rationalisation of that. And it's difficult because you don't want big conglomerates, but 86 for a city of 250,000, it's just not sustainable, really.
Yeah, I tend to agree. One final question, sorry to bombard you, but one final question regarding your sort of market intelligence. How's that obtained from the customer, and how often is that obtained from the customer?
Yes, certainly. We obviously would take any comments or complaints from customers or their families which come through to commissioning to look at if there's a commissioning angle. So we would obviously record that and go through the processes and take action as required. We also have, sorry, my mask keeps slipping. We also have regular contact with our social work colleagues who would feedback the conversations that they have when they assess or reassess and deal with issues. So I think we have sometimes by proxy, to be fair, but we do have a regular feedback from customers that comes to us to collate those issues. I think what we try and spot is trends, of course, for a particular provider. So if the same issue is coming up several times, then that's obviously something that we need to go and address, either formally or informally, depending on what it is. We also, just very quickly, would do the same with our NHS colleagues, commissioning and health teams in the field, and also with CQC. We have a weekly information sharing meeting with the CQC, so we obviously compare notes on providers and information about them. And so, for example, before the CQC go and visit and do an inspection, they would consult our quality monitoring team to see what we think about that provision as part of their inspection.
Thank you very much. Thank you.
Okay, thank you. Just quickly, before we move on, if I may, I've just got some questions really relating to the budget here. I said in the presentation that it costs about 257k roughly a week for care. The council spends that money on care. Can you tell me, does that include so that, obviously amounts to over £1 million a month, and that is a lot of money in anybody's book, isn't it? I just wondered if that does include the cost of the Home First service, which the council is providing.
No, that's on top of that, because the NHS pay for the Home First service. This will just be care packages provided in people's home by the private sector.
Okay, so that doesn't actually include the Home First service, that is very interesting. And does that figure relate to just adult home care, or does it relate to children who...
No, just adults, over 18.
Just adults, yeah. Right.
Only home care, not care homes.
So, okay, thank you. So that is already a lot of money. And so at the moment, we don't have enough people to deliver the job, sadly. And I think everybody recognises that salaries are too low, but on the other hand, everybody knows that budget's tight. I suppose if that, do we currently have the budget, Kirsty, in the council to say tomorrow, you were presented with this dream scenario where 50 people arrive saying they want to work as care workers on your doorstep. Do we then have the budget to take them on and provide that extra care?
Yeah, generally each year we have to try and quantify the amount of growth that we expect, so the number of new people coming through. And there's obviously people who either leave the area or die or move into a care home. So generally we do have enough funds to prioritise home care and care homes. I would say, you know, we're not awash, we're only meeting essential needs. We're not paying for additional nice to-dos. But we've never not been able to pay for a package of care.
Okay, so if the committee would just bear with me a little bit. So we've had the council tax increase this year of nearly 3% to pay for social care. I think that was specifically for adult social care, and we've had that. There's at least 2 million's been added to the budget of the council this year. But bearing in mind you're spending £1 million a month, it sort of puts it into context, doesn't it? And that will be for care, and that'll probably cover care homes as well. I'm just wondering, really, we're anticipating possible further. I mean, I know this isn't your area, Kirsty. You know what happens with the council tax next year, but there's a possibility of increasing council tax by 1% again for over 3 years, in addition to the 10% increase in national insurance, which will kick in from April, the new tax year, to pay for social care. Now, I know a lot of that money initially is going to go to the NHS anyway, but I guess what I'm driving at is we are seeing increased amounts of funding coming forward for social care. So how can we shift this impasse? We've got some money coming in. What can be done, do you think, to try and recruit more people? Would it be putting up the salaries if possible, or wages, or what? Thank you.
I mean, we probably haven't got time to go into it, but there's lots of work already going on directly with care providers, because they know what it would take to try and increase. I mean, just off the top of my head, some of the things, for example, care workers are not on the national shortage list for workforce. So that means they can't be sponsored to come in from overseas. So that would be something providers are asking for. Providers are interested in not necessarily more wages as such, but a range of incentives. So things like Fareed was saying, assistance with travel time. We've had providers suggest things like free parking. You know, the sorts of issues that make the job unattractive are the things that need to be packaged up to make the job more attractive. But primarily, carers themselves say parity with the NHS, a career pathway, is probably the single biggest thing that would make the difference. A recent survey was done of providers, and it wasn't actually more pay. It was, you know, the kind of esteem that care is held in with the public needs to be on a par with how we value the NHS, and it just isn't. So people will always choose the NHS over care. So there's a number of things. I mean, there's a lot of material I could send you if you're interested in it, just about what are the issues around recruitment and retention. But I think it is fundamentally about people do not want to move into this line of work, and most of the people who are working are there for short-term, transient purposes, or are older workers who are coming to the end of their careers. So people are just not making career choices to move into care.
Okay, thank you very much. Councillor Hussain, and then we'll move on, but thank you.
Yeah, sorry for having a second go. Having closely worked in that sector, in all honesty, I think it's the most difficult job you could ever imagine on a day-to-day basis, because what you're looking at is working with people who've got additional vulnerabilities and additional needs. You're looking at people with dementia, mental health problem, learning disability, older people who may have an element of all three different needs. And the pay that we offer to those staff members needs to be looking at very seriously, and I think what's required is a total job restructure. They need to be offered 37 hours a week salary, and we need to compare that salary to other what we are comparing. I mean, you know, they get minimum wage, even that's not guaranteed, because in some cases they probably don't get that 37 hours, and they're desperate to get more hours. In the long run, I think we need to be demanding from the government that there is a total restructure in order to overcome this difficulty. Otherwise, it'll go on and on. It's not got easier year on year. I've been looking at this for 30 years. It's been going in the opposite direction for the last 30 years, and now it's got to a point where we can say we are really in crisis.
That is certainly what the directors of social services nationally are asking for. You know, we're putting sticking plasters really on something that is a systemic issue. So they are lobbying for, of course, more national funding, but actually a complete root and branch review of how we value, reward, recruit this workforce that's much more on a par with the NHS.
Okay, well, in that case, I think we could, thank you, Kirsty, maybe we could make a recommendation to send to our cabinet member, which would be something like this. I was just trying to scribble it down. I haven't finished yet. Something like, we recommend that the cabinet member write to the government to support arguments for a review of how care work is structured with a view to creating, with a view to creating, putting it on a par with the NHS. Sorry? Okay, and improving. So we recommend that the cabinet member write to the government to support arguments for a review of how care work is structured and to improve its terms and conditions. Yeah, thank you. It's probably not perfect, but I think it sort of captures it. Is Councillor Lonsdale, so I can't see that.
It's all right. Should we put something about also adding to the list of people who we can recruit from overseas?
Okay. Are members happy with that? Councillor Pegg? Okay, thank you. So, so we need to insert that care workers are added to the, what's the term? Is it national shortage?
I think it's national workforce shortage. There's a list of professions that can then be sponsored and recruited from overseas, and they're not on there. There's a £25,000 salary cap, or the job has to be of, such severe shortage. So they don't meet the salary cap, and they're not at the moment down for some reason a severe shortage.
You captured something from that, Dom.
Dom can email me, and I can get it.
Could you read it out what you captured, please? Sorry, it's a bit bitty. Thank you.
So, to recommend to the relevant cabinet member to write to the government to support a review of, the terms and conditions, and
it's to support a review of how care work is structured with a view to improving terms and conditions, and then we could add, and also to add care workers to the list of national, what's it called again, Kirsty?
It's like a workforce shortage list.
To the national
roles, certain roles.
Just to emphasise, is everybody happy with that? Yeah. Okay. Thank you very much. Thank you very much, Kirsty. That was really, really interesting, and thank you for your time, and also Kevin. Thank you. Right, we'll move on now to the next report, which is from Joined Up Care Derbyshire, a waiting list update, and that is going to be presented by Sharon Martin, who is the Executive Chief Operating Officer of the University Hospitals of Derby and Burton NHS Foundation Trust. Thank you, Sharon. Well, yeah, that's fine, thanks. You just have to speak into the mic, please, because the meeting's being recorded, so nobody will hear you. Thank you.
That helps, doesn't it? Okay. Thank you, everybody. So I'm actually here, although that is my job title, I'm here as the second job title, which is the Plan Care Senior Responsible Officer. So we have a number of delivery boards across Derbyshire, and each of them has a senior responsible officer who covers that breadth of responsibility for the whole of Derbyshire. So we have a Plan Care delivery board that I sit on with the accountable officer, which is the chief executive of Chesterfield Royal Hospital, just so that committee's aware of the governance arrangements. Sorry, who's driving the slides? Is that me or? No, thank you very much. Okay, so I'm here really just to update on, I guess, the impact of COVID on waiting lists, particularly across Derbyshire. And we had a target pre-COVID around referral to treatment time for routine elective planned care procedures and diagnostics. And obviously we also had cancer targets that have carried on all throughout the COVID. And we're now actually looking at how we do our, what we call the H2 planning requirements. So this current financial year has been split into two halves, H1 and H2. And there is a planning guidance that talks specifically about the recovery that's expected in the second half of the year. And that's particularly, I guess, challenging over the winter period that we're about to enter in, and the fact that we have got lots of people waiting. So the presentation is just really to talk through about how we're approaching that through the Plan Care Delivery Board. Next slide, please.
Sorry to interrupt. Could you just clarify then, does H2 refer to a period of time, or what does that refer to?
Second half of the financial year.
Okay, so. Thanks. And there's no need to do this relentlessly, but there are a lot of initialisms in the presentation.
Yes.
So if you could just say what they refer to, that would be helpful. Thank you.
Yeah, of course. So what we've got here really is just the position of the waiting list for CRH, Chesterfield Royal Hospital, and UHDB, University Hospitals of Derby and Burton. And what you can see here is basically, the waiting lists have increased because what we did have to stop back in April last year, from April 2020, we stopped doing routine elective work. And the big reason for that was, A, to protect patients who didn't need to have routine operations or diagnostics, to protect them from not coming into a COVID environment in the acute hospitals, but also we had to redeploy a lot of the theatre staff that would deliver those elective procedures. Their skill set was something that we needed to use within the critical care, the intensive care. And as we all know, quite a lot more patients were needing critical care, particularly in the first wave of COVID. So it's not a surprise that these waiting lists have gone up because we literally did stop all routine work for a number of months. We carried on doing urgent work and we carried on doing cancer work to a big degree, but even some of the cancer work isn't necessarily deemed life-threatening. Next slide, please. So the particular focus in this recovery plan is around the very long waiters. So and apologies if people are already aware of this, but what happened through the Royal Colleges, particularly the Royal College of Surgery, they came up with a way of categorising patients by the need of their condition. So we carried on. If you think of, there's 6 priority groups really. Priority 1 was people requiring urgent life-threatening surgery. So obviously that carried on. Up to priority 6. So we grouped patients based on their clinical need into a priority level. And what that meant was priority 4 is the least prioritised group, and 5 and 6 are patients that have chosen not to come at this point. Priority 5 patients are patients who don't want to come until COVID has completely disappeared. And priority 6 patients are people that don't want to come at this moment in time. So we've gone through all our waiting lists and prioritised patients. Now, what it means is the longest waiting patients are the lower priorities. And what we've been asked to do is particularly focus on patients who are waiting a year or 2 years. So that's 52 weeks and 104 weeks. So what you can see here, and I do have to, I guess, defend myself slightly here, that University Hospitals of Derby and Burton are a very large elective provider. So we have the 3rd biggest orthopaedic programme in the country. So when Burton and Derby merged, it meant that our elective programme was very large. So proportionally with Chesterfield Royal, it does look like, you know, we have obviously got many more patients waiting. But what you can see on that top graph there is that the number actually of patients waiting over a year has reduced since we started operating again. But the number of patients waiting up to 2 years, the 104 week, has gradually gone up. Now, a big part of that, without making this too complicated, is because we're still prioritising the patients that need surgery more urgently than a year or 2 years. Does that make sense? So sort of examples like that might be a hernia repair, or the removal of a gallbladder that isn't urgent. So those sort of patients have waited a long time, as have some of our patients waiting for joint replacement, so a knee replacement or a hip replacement. And what we've been asked as part of this recovery plan is, ideally, the 2-year wait should be 0 by the end of March. Now, at UHDB, we've said we don't think we can meet 0 by the end of March. Chesterfield have much less numbers waiting, so they have said they will aim to get to 0. What we're trying to do now is make sure that all those patients that we think will, by the end of March, would have hit the 2-year, we're contacting all of those patients and engaging with them to understand, do they still want their surgery? You know, where are they in terms of the priorities? And they're not all surgical patients, but by far most of them are. Next slide, please. So RAG rating just means red, amber, green. So what we've done is we've RAG rated our planned performance against the H2 guidance. So what you're seeing here is a description really of the things that we're being asked to deliver on for the H2 and where we are against that. So the other big part of that is the cancer recovery. And what we were asked to do is to have no more patients waiting over 62 days for cancer, which is the treatment standard, than were in February 2020, so before COVID. Now, that was 99 patients at UHDB, and we've now got way over 300 waiting, so nearly 400. So what we're saying is we don't think we would get back to that 99, but we will reduce the number of 62-day patients waiting. And
okay, sorry, to just interrupt, just as you talk through it, can I just remind you on this slide, there's loads of initialisms. There's EROC, RAS, PFIU. I mean, I don't know what they mean. So if you could mention what they mean, thanks. Otherwise, it doesn't. You know, I tried to read it beforehand. It doesn't mean much. Thank you.
Yeah, and apologies for that. I think we should clearly have made this a lot clearer. So, but to be fair, the main message here is about cancer waiting times and cancer diagnostics. So we will reduce the number of patients who are waiting on a cancer pathway, but we won't hit the challenge that we've been asked to do, which was to get to the February 2020 numbers. Now, a big part of that, which I think is technically a good news story, is that during the 2 big kind of lockdown periods of COVID, we saw patients not going to their GP with cancer symptoms. So we saw a big reduction in cancer referrals into both Chesterfield Royal and Derby and Burton. And we think that was basically because there was no campaigns about cancer. Patients were probably staying at home, and COVID was the big thing that everybody was trying to, avoid and recover from. And that's not a good thing. That doesn't mean that cancer was not there to be diagnosed. So we saw this big reduction, and now what we've seen is the cancer referrals have gone way over the numbers that we had pre-COVID, which is a good thing, but it means that it's taken us longer to get through those patients. The faster diagnostic standard, so that's the FDS, that is a standard that was brought in by the government last year. And again, we've been asked that we must meet that by the end of March. Now, we have already been meeting that target for some time. That is about from referral from the GP to the patient knowing whether they have or haven't got cancer should be no more than 28 days for 75% of patients. And we do think we can continue to achieve that. It is challenging because it means patients obviously have to get all their diagnostics done, and they, as I say, with this big increase in referrals, that is more difficult. Next slide. I'm conscious.
Just to interrupt again then, please. So what does CRH refer to?
CRH is Chesterfield Royal Hospital.
Okay. What does PIFU refer to?
Sorry, say that again.
PIFU.
PISU.
Just, yeah,
sorry, patient-initiated follow-up, sorry, yes.
Okay.
So that is a national programme that the government have supported us when we work with patients, and there's a bit more in the slides later on about how we communicate with patients about where they are on the waiting list, etc. And through a discussion with a patient, you can have an agreement about agreeing a follow-up with that patient rather than proceeding to an outpatient appointment.
Okay, I've made this point before when we've had, not yourself obviously with respect, but when we've had presenters from the hospital, etc., that it doesn't mean anything. PIFU is a proportion of all OPA.
Yes.
What's OPA?
Yeah, outpatient appointment.
Yeah, I mean, it would be possible to either provide a glossary or to write that, because there's no point providing with the slides and then with respect and then saying, well, the main thing here is about cancer. I mean, the word cancer isn't used on the screen, and it's not intelligible for people who aren't working within the system.
I appreciate that.
And it is frustrating because actually, I think we do want to know some of the detail. Thanks, but if you could take that back, please.
Of course I will.
We mention it.
And I'm very happy to send a glossary on so that this can be interpreted better.
Okay, thanks.
Next slide, please. Thank you. Yeah, and this is the cancer activity as well that I just talked about. So these are the two things that we were just talking through around the 28-day standard. So the next slide, please. So another thing that is really a focus for us in the Planned Care Delivery Board is about how do we, so I've just talked about a big proportion of those patients don't have a date for surgery and are not deemed to be time critical. So how do we then make sure that we're what we would call risk stratifying those patients? So how do we know which patients have other comorbidities or other things? So if I had 10 patients all waiting for a hip replacement, and none of those are deemed time critical from the hip point of view, the patient might have other risk factors such as diabetes or heart problems, and we need to make sure that we're working with primary care, we're working with the GPs. So this standards framework came in last August and allowed us to focus in on the GP communication, the patient communication, and making sure that we were having some clinical reviews of patients whilst on the waiting list, and making sure that we were doing an RCA as a root cause analysis and looking at any harm reviews. So a lot of work's been done through the quality teams, and one example is patients on an upper gastrointestinal pathway, with the aim of looking at those patients in particular, and this was done at Chesterfield, looking at a range of patients on the waiting list and checking out whether they were coming to any harm whilst they were on the waiting list. So that we could risk stratify what we might need to do in order to bring some of those patient cases forward. And that's quite difficult when you've got thousands of patients who are on those waiting lists, but it's really important that primary and secondary care work together to try and do that. And it's a conversation that we have on a very regular basis. We've just produced a video that's gone out on the Joined Up Care Derbyshire website for patients that talks about what they need to do should their symptoms increase, etc. And we've written to all our patients from both Chesterfield Royal and Derby and Burton to explain if they're on a waiting list, what they may need to do. And that isn't always just about going to the GP. That might be about us reviewing them in clinic just to see where they are in terms of their disease process. Next slide, please. And so we've also looked at how do we work across Derbyshire, because there are a number of providers. It's not just the 2 acute hospitals. We've also worked with the independent sector as well. And what we've found is that we've got, differing weights in different parts of Derbyshire. So we've been doing some work right across the system through something called the Midlands Elective Recovery Programme, where we've looked at a number of specialties, particularly these ones that might be deemed to have less high-risk patients in terms of the long waits, so orthopaedics, ophthalmology, general surgery, and we've looked to see how we can get the best sort of pathway design for patients. So are we all doing the same thing? Is Chesterfield, Derby, Burton, the Nuffield, are we all approaching those pathways in the same way? And also, have we got differential weights? So if I was a patient on a waiting list at Derby, might I be waiting longer than at Chesterfield? And if that's the case, we should be offering patients the choice to go somewhere where there's a shorter wait. So that's been the main thing from that. But of course, patients don't necessarily want to travel either. So we still need to be mindful that we need to be providing services local to home as well. Next slide, please. And then the other thing that we've done an awful lot of work with is trying to look at the referral stage prior to somebody coming into a hospital pathway. How can we work with GPs to look at the best way really of managing patients? So there's something called advice and guidance, which might be about just supporting patients before they actually need to be referred in for a hospital consultation. So there's a big programme of work looking at the pre-referral stage and checking that patients do meet that clinical threshold for an actually hospital referral, and if not, what do they need to do with support for their GP? And that's really about managing that demand, but also managing the patient's expectations. Next slide, please. And then in terms of the primary care clinicians, because of course a lot of our GPs have been involved in the vaccination programmes as well. So we're very aware that primary care has been under an awful lot of pressure. So what have we been asking primary care clinicians to do in order to help patients? And there's just some examples of what primary care have been able to do. And there's been some good progress, I think, with other developments that perhaps pre-COVID we were struggling to look at. So there's something that has been agreed across Derbyshire, which is around community diagnostic hubs, where we are actually going to get more support out in some of the community sites. And I know Will's here from Derbyshire Healthcare, where we want to actually get more diagnostic centres into some of the community sites. So that GPs can actually access diagnostics before referring patients into the hospital, because that's something GPs have been asking for some time, their ability to actually make more of a diagnosis in primary care before doing the ongoing referral. Next slide, please. So what are our next steps? So there's still quite a lot of work that we need to do to meet that H2, that second half of the year expectation and beyond. And we continue to think about this as a system approach as opposed to what's happening at Chesterfield or what's happening at Derby or what's happening in the community. The risk stratification, as I said, about the waiting lists as well, making sure that we are prioritising patients, continuing to look at individual patients and what's happening with certain cohorts of patients should they be deteriorating. We have quite a large bariatric programme in Derby, so we're the provider of bariatric surgery for Lincoln, Nottinghamshire and Derbyshire. And bariatric surgery was considered very risky during COVID because a lot of those patients have comorbidities. So that's one of our big areas of waiting time for patients. So we are looking at whether we can get any national support to allow bariatric patients to have their surgery elsewhere. So these are patients who've been through a weight management programme and waiting for bariatric surgery. And we've surveyed the patients waiting and asked them whether they'd be prepared to go elsewhere. And a big proportion of these patients would be prepared to go elsewhere because they're really keen to get their surgery. We've then also had something called Targeted Investment Fund. So that's where we've been allowed to bid for some additional funding. Some of that has been on the digital side, and some of it has been for a state where we may want to do additional things to speed up the recovery. For example, some theatre equipment that we might need to do and improve our throughput through theatre. And then I mentioned this right at the beginning, how we manage winter and protect the elective recovery, because quite often during winter, we do reduce the amount of elective work we do and use the bed complement in the acute hospitals for emergency patients and reduce the elective work. And we can't do that this year. So again, we're working right across the system on looking at how we manage, and we heard from Kirsty earlier, the problems we've got with care packages, etc. We're not obviously leaving that just to Kirsty to deal with. She's a big part of our system approach about how we work together to look at making sure we've got sufficient capacity out in the community to support discharge from hospital, but also admission avoidance. And then looking at our internally, particularly about how we improve our theatre efficiency. Next slide, please. Should be the last one. Thank you. Sorry, that was a bit of a whistle-stop tour of what is quite a complex mix of things that we're trying to deliver through planned care.
Okay, thanks very much. Yes, I thank you. It clearly is a lot more complicated than just the stats, but that was very interesting, thank you. And sorry to be rather pedantic about the initialisms, but I keep making this point, and I will keep making it to the NHS, because it does make it a lot more interesting to look at beforehand when you don't have things that you don't understand. But thank you very much for that. Any questions? Councillor Lonsdale?
You said that you weren't going to meet the challenge of the cancer treatments for obvious reasons, but I was wondering if you have a projected time when you might meet those challenges. What sort of time frame are we thinking of? Are we thinking a year hence or 2 years hence before you're able to meet those challenges?
That's a really good question, because we weren't meeting those targets pre-COVID either. So that the 62-day target says that 85% of patients, which doesn't seem a lot, should have had their treatment completed within 62 days. And neither ourselves nor Chesterfield were meeting that before. And actually, nationally, it wasn't being met either. So I think it's quite difficult to say, would we get to a point where we're achieving that 85% with the numbers that we're dealing with? What we've got to do is get closer to that, and we've got to work really carefully on the more risky pathways that the cancer is very time critical. So there's a range within some of the cancers that may not be quite as time critical. If I give you an example, dermatology cancers are often hitting that target because a skin cancer can actually be seen, treated, removed, sent for histology, sometimes just in one visit, whereas somebody who needs complex head and neck cancer might need several diagnostic visits, need quite a complicated surgical procedure, radiotherapy, chemotherapy, following that as well. So we look at it on a pathway basis and look at condition-specific cancers and aim to try and improve those as we go along and show that improvement. And I think that's what we really should be focusing on.
Thank you. Councillor Hussain.
Thank you for your very informative presentation. I know National Health Service, to an extent, was struggling a little bit before we got COVID. Waiting lists were generally going upwards.
Yes.
Now, obviously, COVID has made things more difficult, and I think you've done a wonderful job, through the crisis period, and NHS staff generally who've been very, very dedicated and they've done their best. But realistically, do you see waiting lists coming down in the next 5 years? Or do you think all these various efforts that you're making, they might slow down the build-up?
Yeah.
Actually, we might not see a decrease in waiting lists for the next 5 years or so?
I think you're absolutely right. We've projected that our overall waiting list could take 3 to 5 years to recover. And that's assuming the rate of referral we've got now. So if we were to see an increase in certain, certain pathways, that might not be achievable. So I think, it is a problem that is not going to be a quick fix. Yeah.
Councillor Pegg.
Thank you. Will reducing the 104-week plus waiting list impact on the 52-week waiting list?
Ultimately, yes. I'm sure you can imagine the waiting list it's kind of like a bulge that moves along, and the complexity I think that we've got, that we've created ourselves in a way, is that we keep taking off the priority patients, and some of the longer waits just move further and further along. So it's quite a complex pattern, and what we have seen with those 52 weeks is we've seen them coming down, but again, depending on the type of patients that we get referred in, we could see that grow again. So it's not an exact science in terms of, because it depends on the mixture of patients that you've got coming through. But I think, it's important that we don't really want to be having any patient waiting longer than 2 years. That just does not sit comfortably with anybody.
Thank you.
Thank you. I'm aware of at least 2 people I know socially who have needed hip replacements and have just gone private because they were in pain and they could afford to pay and they didn't want to wait. So I don't know if that would be classed as something that, I think their understanding in both cases actually was they would take 2 years to have their hips replaced. And of course they're not young people, not that young anyway to begin with. Yeah. So I don't know if they were the kind of people where you might suggest that they don't have immediate clinical need, but they were certainly in a lot of pain.
Yes.
And so basically I'm wondering if you have any figures on the amount of patients where they're obviously able to, and some people are, where they've just gone private.
I haven't got those figures. I think it's quite an interesting one, because if I take Derby Nuffield, which do quite a lot of orthopaedics, it's our surgeons that go to Derby Nuffield, and during COVID we didn't do private practice. They were doing all NHS work, and we had to select the right sort of patients to go into the private sector. So some of the more complex work can't be done privately. If you need, so again, it comes back to that risk stratification. If you've got comorbidities, then there will be restrictions on where you can actually have that surgery done. So depends on the surgeon, depends on the individual's physical state, and depends on the setting. So some private hospitals do have a high dependency, but the ones in Derbyshire don't. But I haven't got any figures about how many patients have chosen to go privately during that period, but quite a lot of the private work was ceased as well.
Yeah, I mean, it's obviously recommends because they both had it done. One had it done in February, and one's having it done in January. So it's obviously recommends some time ago.
Yes.
Well, do you have any sense of how many people who have been recommended for surgery then just fall off your waiting list then? We don't know if they've gone private or they've decided not to pursue the treatment.
Usually the patients will tell us, that they'll ring us up and let us know that they either no longer require the surgery with us and usually give a reason. I'm not hearing that's lots and lots of patients, to be honest. I'm not hearing that from certainly not from orthopaedics.
So you don't have, I mean, and I'm also thinking about people who give up the ghost and just think, well, I'll live with this, or I'll just take my chances.
Yes, so those patients, the ones that we are speaking to, we're it sounds awful to categorise, but they're classed as a priority 5 or a priority 6. So there are patients that are saying, I don't want my surgery yet, I'd rather delay it, but we keep them on the waiting list. But we put a note against them saying that they've chosen not to have their surgery at the moment. Or some might say, I want completely taken off the waiting list, in which case we would, and we'd ask them to be re-referred.
But do you have any sense of how many people that is?
So out of the 104 weeks, those patients waiting 2 years, I've got about 17 patients who are priority 5 and 6 who've said they don't want surgery yet, out of over 100. So it's a small number, really.
Okay, thank you. Any other questions? No. Well, I think I would have other questions, but I'm aware it's now 20:08, and we have a few other presentations to hear. Thank you very much for that. It's really interesting. I think you have illustrated for us how complicated this is, and we know the NHS is working as hard as it can, but also we know that turning to primary care is not the answer, because we know from previous presentation we had last time that GPs are totally under stress, and now the government is promising to up its vaccination programme. So it seems to me that there's pressures all round. And it's very honest of you to say that it was going to take 3 to 5 years to recover. Thank you very much. Thanks. Okay, now we move on to older people's mental health consultation. Claire Haynes?
I'll speak for Claire.
Okay, I was going to say we don't have a Claire Haynes in the room,
no,
I'm sure.
I'm in disguise.
Sorry?
I'm in disguise.
Right. Okay, thank you very much then.
So yeah, it's Mick Burrows from Derbyshire CCG. I'll just give a quick preamble to sort some context into this. So, Chair and Cabinet colleagues, you'll remember a few months ago we came and presented a large-scale mental health reorganisation of our estates, and that included a psychiatric intensive care unit and new units over at Hartington unit and Radbourne unit. This presentation tonight has got two elements to it, two very distinct elements. One is a proposed move to look at improving older people's mental health inpatient estate. That's not happened yet. It's a proposal we need to talk to you about and get your views and your input. The second is a consultation on a move that's already happened, but it happened for organisational reasons and operational reasons that are largely beyond our control. And that was around the moving of estate from the what's now the Florence Nightingale site to the Kingsway site, again, older people's mental health. Both of these proposals are around the amalgamation of older people's mental health services and bringing them closer together to provide better estate, better facilities, and more age-appropriate estate and facilities for people of older age. So I'll pass on to my colleagues who will give you the details of these two proposals.
Okay, shall I kick off, Will? In terms of the older adults mental health service in northern Derbyshire, the proposal is to move the 12 beds that are provided for that service at Chesterfield Royal Hospital, some 2.5 miles across Chesterfield to Walton Community Hospital. At the moment, the older adults service is provided in from 12 beds in a 20-bed ward shared with working age adults and in dormitory-style accommodation. So as part of the work that we spoke to you about a few months ago of eradicating dormitory-style ward accommodation, this proposal would move the older adult service into a ward that is already good quality single ensuite rooms on the, as I say, on the 2.5 miles across Chesterfield, and that together with the new build for the working age adults would then eradicate the dormitory style wards for acute mental health illness in northern Derbyshire. In southern Derbyshire, the consultation that's being proposed is, as Mick said, to confirm the temporary move that took place for the older adult functional mental health service, moving from the Florence Nightingale Hospital to Kingsway Hospital. Again, the accommodation that is available at Tissington House at Kingsway Hospital is updated, modern, single ensuite rooms, the style of accommodation that we would be seeking for all of our patients. There has been very, very good feedback from service users and carers that's included in the paper around that temporary move, and we would be seeking as part of this consultation both current patients, future patients and carers' views on making that permanent and on the relocation of the northern service to Walton Hospital.
Thank you. Is there anything more to add to that?
Thank you, Chair. Just I'm here to represent the Walton Hospital part of what my colleague has explained, and at the moment we run 30 old age psychiatry assessment beds at Walton Hospital, and the reason that we're able to accommodate the 12 beds from the Chesterfield Royal side of things is that we've been successful over the last 3 to 4 years in reducing the demand for those beds due to the introduction of the dementia rapid response teams which came in 2018. The occupancy of the current 30 beds available at Walton Hospital has reduced significantly. We have 2 distinct wards, and we're confident that we will be able to accommodate the 12 functionally ill beds and to be able to meet the demand for the old age organic mental health assessment. Thank you.
Okay, thank you very much. Right, do we have any questions? Councillor Hussain.
Chair, last year we had a presentation from Mental Health Services, and that was about relocating older people with mental health problems to Kingsway side. And there was also a proposal there for a purpose-built site on Kingsway. And I was led to believe that those people who are being moved will actually be moved to a purpose-built site at Kingsway. I'm a bit confused now. is there a suggestion that some people will be actually moved from Derby to Chesterfield to receive some services?
Can I respond?
Am I confused what's happening?
Councillor was saying that the proposal was brought last year, beginning of COVID, which came and sort of halted things a little bit, was wards 1 and 2 at London Road have clearly benefited from both a dementia rapid response teams and a functional rapid response team, which has enabled those 2 wards to be amalgamated into a single ward. Tissington House is the purpose-built older age unit at the Kingsway site. So what we're proposing is the move that has taken place, closing 1 ward, 2 wards onto 1 ward because of the impact of the community teams. That's enabled now for Ward 1 to be able to move over to the Tissington site, and that ward at the London Road site be used for UHDB's own purposes. So, and that's Derby patients moving around Derby Estate. There is no suggestion, or we're moving Derby patients to Chesterfield. The second suggestion is that we're moving the site on the Hartington unit, which was a unit that was split between older adults and adults of working age, to a site just across the other side of Chesterfield to Walton Hospital. So they would have the benefit of a purpose-built, ensuite provided, older persons environment that's more conducive to care nearer to them, and that would eradicate the dormitory problem in Chesterfield. So there's no suggestion of moving people around the county.
Thank you. Does that explain it, Councillor Hussain? Thank you. Yeah, it does. There does seem to be quite a lot of movement. I do remember you put a report on in the period that I'd been a chair, and it did seem very impressive when we looked at it. But I agree that then you step back and it sounds rather more complicated than you thought. I'm sure it isn't. It's just if you're not working in it every day, it's a bit unclear. It can become unclear as to what's happening. Councillor Lonsdale.
I also remember this report coming while I've been vice chair. One of the questions we asked back then was about transport links to Kingsway. It is not an insignificant walk from the nearest bus station to Kingsway. If we're talking about someone who is less mobile and maybe using public transport, I do it regularly myself as a resident of the Kingsway estate, the Manor Kingsway estate. So has that been thought about or addressed from our questions from last time?
Yes, certainly. At the moment, we're in conversation with the local bus company who's looking to provide a local bus route that would actually go through the estate, linking the main bus routes with Kingsway. That isn't confirmed yet, but we are in conversation.
All right, I have a question, thank you. It relates to the situation in Chesterfield, and thank you for coming and thank you for sitting so patiently through all this to tell us about Chesterfield. I have some political links in Chesterfield, so I feel I know it reasonably well, but I probably don't know it that well, actually. And I think Councillor Hussain's right to draw this question, because this is something we had when we were talking about taking stroke patients away from the main hospital in Chesterfield and possibly bringing into the Derby, is that although they're all part of the same county, the affinity between Chesterfield and Derby is not socially or to some extent geographically, but certainly not culturally and socially. It's not very strong, interestingly. So thank you. So Walton Community Hospital, is that sort of within Chesterfield as a town, it's not a city, is it as a town? Is it on some other edge of Chesterfield?
It's very much in Chesterfield town, Chairman. I think it's, I know, the Chesterfield Royal Hospital site is actually in an outside village called Cavel.
Yes.
Whereas Walton is a section of Chesterfield, and I would consider it probably a mile from what would be considered the town centre, whereas Chesterfield Royal Hospital at Cavel is probably 2.5 miles away from the town centre.
Right, thank you. Yes, I know where the Royal is. So basically it's very accessible, it's been more accessible, arguably, for a lot of people in Chesterfield.
Yes, I think that would be a fair assumption to make.
And then you're reducing the number of beds from 30 to 12?
No, Councillor, from 30 to 15.
Oh, 15, sorry.
So there are what we classify older people's mental health beds in 2 categories. There's the functionally mentally ill, and they're the beds that are currently on the Chesterfield Royal site, which is 12 beds. And then we classify the other need for old age psychiatry as the organically ill, and there are currently 30 beds available on the Walton site, and the proposal is to reduce to 15 so that we can then bring the 12 beds from Chesterfield Royal to Walton Hospital.
So it is a reduction from 30 to 15, yes?
Yes, it is.
Thank you. And so, so just for clarity, and bear with me on this, so you're saying that because of the work of the Dementia Rapid Response Team, so does that in effect mean that you're keeping people out of hospital, you'll be able to give them some care at home, and so you can, that's how you need fewer beds in the hospital?
Absolutely correct.
Yeah. Well, I think when we looked at this with respect to the Kingsway, I think the move away from dormitories to more individualised living is sort of obviously sounds excellent. I suppose the only concern we might have is that reduction in numbers of capacity, given, as we've all heard tonight, that, you know, often support in the home is either not available or is difficult to sustain. Do you have any views on that, please?
Thank you. Excellent question in the context of Kirsty's earlier presentation. All the feedback we've had in the north of Derbyshire since we introduced the Dementia Rapid Response Team service in 2018 has been extremely positive. And as we've heard earlier this evening, if you were to ask the people themselves and their carers and loved ones and families where they would like to be cared for and assessed, generally speaking, it's always in their own home. And the Dementia Rapid Response Teams have proven to be extremely successful in reducing the demand for hospital assessment, specialist assessment, and the multidisciplinary teams outreach and work in the families' homes. And there are some examples in the paper this evening where this has been extremely well received.
So, did you want to come in at all, Councillor Pegg? So just on I'm not sure if you want us to make comments on the consultation. Is that as such, or?
Happy to take any comments, but we were wishing to brief you in terms of starting that public consultation for 2 months, actually tomorrow.
Right, so you are starting it tomorrow, but because you haven't really said anything. I mean, we don't have lots of time, so I'm not trying to extend this unnecessarily. It's just that I'm not sure that we've quite given you what, because I think before we did express our appreciation of this move to kind of more bespoke living, if you like, and provided the services can be maintained, I'm sure that is a good thing that more people can be treated at home. The issue is you did say you wanted comments on the consultation. Is there any, I mean, we haven't told us what it's about, so is there anything you want to say on that, please?
So basically, as I was saying earlier, the consultation is covering the two distinct elements.
Oh, sorry. I mean, what I mean is, in terms of how, do you want us to comment on how you're going to consult? Are you just basically telling us you're undertaking the consultation? You're not going to tell us exactly how you're doing it. You don't want any feedback on that.
We are happy to do it, to take any recommendations that you've got. What we will be doing is putting that out as a consultation to current service users, potential future service users, carers, stakeholders that within the local community and the public. So.
All right, thank you. Does anybody have any comments on the consultation per se? No? There are no further questions on this. Well, thank you for coming to tell us about this. It does sound very positive potentially, and I hope the consultation is useful and helpful. I'm sure you'll try and contact as many people as you can and make people aware of it. And yeah, I hope it supports what you... I mean, you could perhaps be interested to hear, just if you could send through to Lindsay Stevens, perhaps, the results of your consultations when they come through. That would be interesting to have, please.
Happy to do that.
Yeah. Okay, thank you very much for coming along tonight. Thank you. So now, very quickly then, we move on to the Symphony Healthcare Development, and that is going to be presented by Raya Reiki. Thank you.
Hi, yeah, I'm Raki Raya, and I've just come to fill you in on this new health centre that's being built in Symphony, hopefully. So I'm sure you've been to Symphony and you've seen the levels of deprivation that are in the area. We've been given an opportunity to work with NHS England to build a potential new health centre near to the current GP practice. The unique selling point of the centre is the fact that it is community-based. The idea is that it will be flexible, so that it's not just NHS providers that use it, that it is the voluntary sector as well that can use the centre to help the local population.
Thank you.
So yeah, I think I've kind of covered that slide. If you want to go to the next one, sorry. Sorry,
I interrupted there because I was astonished. I thought you were looking at me as if you'd finished, and I was thinking, crikey, this is disciplined presentation.
You're trying to get you back on agenda. So what we've done so far is we are looking to buy a piece of land by the current health centre that is owned by Asda. We have agreed a valuation price for that, so we're going to go ahead and start the purchase process. In parallel, we've been working with the local hospitals and different voluntary sector organisations to see who would be interested in being an occupant of the building. So on the screen at the moment is a list of different organisations that are interested. A lot of this is linked to... Take my mask off. This is linked to Public Health England data for the area that sort of tells us where there are real problems and how these different organisations can help with that. Next, yeah. So yeah, when I sent this slide in, we hadn't agreed the valuation price. We've since agreed it. We're in the process of designing the building and getting the initial layout approved. We want to try and do further comms and engagement with the public just to ensure that we are providing a centre that will give them what they need. And then the next steps will be about applying for planning permission next year to start building the year after. And that's it. Thank you.
Thank you very much. That was short and sweet. Any comments or questions on this?
Well, all we can say is we wish you well, and I hope everything goes okay with you and you get up and running those services that you are aiming to run.
Thank you.
Yeah, absolutely. I mean, I do have a quick question, actually. It is actually about timescales. So you say that you're looking for planning permission next year. So you're anticipating it being open and running in 2023. Is that correct?
2024. It's just taking a lot longer to dot the I's and cross the T's than we anticipated. So yes, it'll be back end of 2024.
So just to, is there anything that could basically stand in its way? I mean, is it quite a long period of time before it's planned to open, and budgets change, governments possibly change, priorities change. There seems to be reshuffling of health organisations in the city, joining together, parting, reaffiliating. It's a whole myriad of stuff happening, isn't there, managerially? I mean, it seems like an extremely positive development, and I'm sure everybody thinks that. It's just, is there anything you're anticipating that may prevent it from happening, stand in its way?
The project is a pilot programme with 5 other centres across England. So in terms of our Symphony centre, it's pretty likely to go ahead because it's part of the pilot. It would be what would happen with future centres, I guess, is more at risk.
And are you confident you can recruit GPs to work there?
That's one of the risks on our risk register, is about recruitment of clinical staff.
But you're going to try, and at least you'll have a centre for them to work in.
Yeah.
Okay, and it does look excellent. So the only other point I would make, and I think it is really, really important, I'm sure you know this, to actually talk to local people, because obviously I'm sure there's a basic service that you're obliged to provide, and something that they think they should have that they probably don't know about, which is fair enough. But in terms of the other services, then it's really important to talk to people, because very often they do have a sense of what they need and what they will work with and not, and that often working with people is by far the best way of doing it.
Yeah, definitely, I agree. We've done 2 public engagement sessions via Zoom, and now we're looking at what else we can do within the remaining safe within COVID, and how we can engage further.
Okay, well, if there are no further comments on that, thank you very much for coming. That was very short, but it does seem very positive, and we look forward to hearing more about it, maybe when you're up and running, or this committee, whoever will constitute this committee by then. But thank you for coming. Now we just have to very quickly turn to our work programme and topic review. On the topic review, we have shared some times and some details of some people we are talking to on Thursday, so everybody should have had that. We've also sent out a letter to care homes inviting people to come and talk to us if they wish to. On the work programme, we do have a very full work programme. Is there anything else that people would like to raise about that now? It is that way. Reiki. Okay, that's okay. You go. Yes, that's the correct way to leave. That is correct. You're the only one who's followed an instruction this evening. Thank you. Is there anything else anybody wants to add to that? No? I would just like to, I don't have anything to add either. We did see the Health Watch report on dentist services, dentistry, which was also referred to in the Derby Telegraph today. But we do have we actually have a report coming on dentistry next year. So we'll engage with that one, and perhaps the Health Watch report too at the same time. And the only other thing I wanted to ask you was, given that the government is understandably announcing an expansion of the vaccination programme, and given that we know how serious the problems are with GP access, and given that we know that, I think it was, the figure was something like 57%, as I remember correctly, of the vaccinations were provided by, would given by GPs. I was wondering if I should write on behalf of the whole board, once again to Dr. Chris Clayton, who is the CEO of the CCG, to ask him if it is, possible to release GPs, if it's possible and appropriate to release GPs from delivering vaccinations to as much as he can, so that they're more available for surgery appointments. Councillor Pegg?
Just as an aside, I know my GP surgery aren't doing the booster jabs. They've stopped doing it to concentrate on patient appointments, etc. But what is interesting, no one seems to know who is delivering, for people housebound, who is delivering the booster jabs to them.
Well, the housebound, that is a question. That's another question I could ask him then. Who is delivering them to the housebound? I know they are still using GPs to deliver quite a lot of the vaccination program, and there may be good reason for that. I think it's really a question of me writing to him and just reminding him of the importance of GP. Your surgery is obviously good that they are focusing on appointments, because it just seems obvious that more pharmacists can deliver vaccinations, nurses can. So their work is also important, but whether, given the shortage of GPs, we could ask that. So I could ask that, and also about the housebound question. So if everybody agrees, I will do that on behalf of the whole committee. Thank you. And then very finally, we just have a point for information on the St Thomas Road surgery reprocurement. Does anybody have any comments on that at the moment? No? No? Okay. In that case, thank you very much for attending, and I close the meeting. Thank you.